This is a video of type 3 subtotal cholecystectomy for acute gangrenous cholecystitis. So, this is a view of just seeing the peritoneal cavity from the umbilicus camera port. There is no collection anywhere, and clinically it is like a mass like. So, you can see around the entire right hypochondrium epigastric region there is a mass. Omentum is adherent there, and omental adhesion extending up to the left side. That is the left lobe of liver. So, I cannot make the epigastric port, so I make a left lumbar port. So, with this 5 mm port with a harmonic ultrasession scalpel, I am just dividing the omental adhesions, and this is little late presentation. So, a lot of neovascularization was there between the omentum and the peritoneum. The patient treated somewhere and then they came late, and you can see this camera is not a 4K, it's a HD. It's a long back. It was done in 2019, almost around 6 years before the surgery was done, and there's a dense omental adhesions. When I going close to the gallbladder area, it was so dense. So now I have a space to place right subcostal port, and this is the epigastric port. So I put a 5 mm, and when I time of clipping, I change to 10 mm to the epigastric. So I just with the two instrument, I am just slowly entering. I have to go between the abdominal wall and the omentum. It is very dense adhesions, late presentation, and there is a huge abscess cavity is there. It's clinically mass, and in imaging wise there is a abscess cavity. So I am starting as usual. We have to start from medially. This case it's extending lateral, left lobe of liver. A lot of pus collection. You can see dense, very even with the suction, continuous suction, it is spilling out. So that much, dense, big abscess cavity. So all the pus, frank pus is coming out. So I am just sucking out all the pus, and the thorough wash is being given. So once it's clear the content, pus content, then we can, still we don't know where it is there. So I'm just, the omental, one the ceiling will open in one place. I could see very, lot of pus, and you can see the gangrene portion of the gallbladder there. That is a gallbladder wall, it's totally gangrene, and very small space. So I'm trying to enlarging the space. Simultaneously the pus so now you can able to see here it is enlarged, and that is the gallbladder, and you can see here it is a huge, very huge abscess cavity that is between the diaphragm and the right lobe. You can see so much pus is there. So very long virulent organism and long standing, not respond with the medicine. So entire gangrene gallbladder with a lot of pus, huge subdiaphragmatic abscess cavity. Just a simple gallbladder is making this type of problem. So if it is a mild symptomatic, immediately we have to operate. So now there is a adhesions of liver to the subdiaphragm is also there. So now I am trying to release the adhesions so that I can able to see the liver well. So this is very dense adhesion. That's why it is not perforative peritonitis. It is not a diffuse peritonitis. It is a concealed because of this omental seal to the liver and the abdominal wall. So it is protecting such a bad infection. It is not spreading to any other quadrant of the abdomen. So now I could able to see the liver surface. So from this I am separating the omentum. Wherever it is dense, I am using a ultrasession scalpel to release the omental adhesions, and you have to be careful about the colon. You can see the colon is visible now. Your instrument should not injure the colon. The vision will be little poor because it is a HD camera. That time the 4K, maybe that OT will not have that 4K that time. So there is a huge cavity. So I am releasing the adhesions of the liver to the abdominal wall, diaphragm. Basically, it is a diaphragm. very bad abscess, huge amount of pus, almost more than a liter of pus was there. It is sucked out and we have to give thorough wash, and then so this is the gangrene gallbladder. So first thing is wash to be given, then we can proceed for the cholecystectomy. In this case, as I mentioned before, it's a type 3 subtotal cholecystectomy. I leave the anterior wall, posterior wall of gallbladder to the liver bed, and some of the anterior wall of the gallbladder to the duodenum. So it is a type 1. And then infundibular mucosa, infundibulum, part of the infundibulum I left, mucosa is of the infundibulum is removed. So it is a type 2. Since type 1 and type 2 is combined in one case, it is called type 3 subtotal cholecystectomy. Because of the acute inflammation, a lot of oozing is there, and all the blood will absorb the light. So you will see the image is little, no, it's not a very bright. So that is a disadvantage of this high definition cameras. If it is a 4K, this problem will not be there. So I am trying to separate the gallbladder from the omentum or the duodenum. So I could, you can see only the mucosa is being separated. The anterior wall of the gallbladder I left on the duodenum. The gallbladder got open, and you can see a lot of small black color pigmented stones. These stones, if it is spillage, is very difficult to take. So what you do, you have to take it immediately. So I am trying on the medial side from the quadrate lobe. I am trying to separate. If I see the anterior wall of the gallbladder, I can take out the omentum. So this type 1 modification will be avoided. So just I am looking for that. So it is very dense. No, it is a very late presentation. It is not possible. So I am just using the ultracision. The entire gallbladder wall is become gangrene. So to prevent the perforation, so omentum will seal nicely, omentum and the duodenum. So we have to be very careful not to injure the duodenal wall. And I'm just again I'm looking for the more medially. Is it possible to get any cirrhosis of the gallbladder? I am not able to getting it, and a lot of bunch of small stone filled up with the entire gallbladder. I'm using a 10 mm stone holding forceps. I convert into epigastric port into 10 mm. This is a 10 mm stone holding forceps. Otherwise, the stone will spillage. It's very difficult to remove. And if you leave any stone, it will produce postoperative abscess in that area. So I have to remove the entire stone. That is the first important work. If it is a multiple stone, remove the stone first, then go for a gallbladder dissection. Our mind says, okay, we'll take out the stone later, but it is very difficult. So sometimes I use a 10 mm suction catheter. We have a 10 mm suction nozzle. So this is the 10 mm suction nozzle. So it will suck all the, we connect to the powerful suction. So we can able to suck out all the stones. So this is the way, easier way compared with the stone holding forceps. Even though it's a 10 mm stone holding forceps, sometimes it's difficult. So I'm using a stone holding forceps now. 10 mm size and suction nozzle 10 mm. So both alternatively I am using it. So once the stone is completely taken out, then we can go for a gallbladder dissection. So now you could see some of the anterior wall we can able to find out. That is the infundibular region. The anterior wall is little bit, it's not gangrene. Mucosa got gangrene, might be the anteserosa, it is looks pink color. Some blood supply still has the hair. So it is a very wide infundibulum. So I am trying to mobilize the infundibulum so that I can able to see the cystic duct. I can able to clip it. So there also you can see the impending perforation is there. So it is a subtotal is a well accepted procedure. Only thing you have to clear all the stone and you have to remove all the mucosa and the infundibulum to be sutured very nicely without any bile leak. So these are all the criteria if you followed and subtotal. And the infundibulum, you should not leave a long in the entire infundibulum. It should be very small pouch. Otherwise, what happened? If you leave the mucosa without taking the mucosa, if you suture the infundibulum, the mucosal secretions after some years, maybe 3 years or 4 years, the patient will have a distended infundibulum with the collection inside, the mucosal secretion. On the ultrasound, it looks like a gallbladder. So the sonologist, he knows the history of cholecystectomy is there. So what he did, he does is, he will give the report as a remnant gallbladder. So that's why when you're leaving, when you're going for a type 2 subtotal cholecystectomy or type 3 subtotal cholecystectomy, you have to take out the entire mucosa of the infundibulum. That is considered very, very important. Otherwise, the secretion will form, it will distend it, and then it will enlarge the infundibulum. It look like a part of the gallbladder on the imaging studies. So now you can see I'm taking the, in trying to take out the infundibulum, and it is the entire mucosa got gangrenous. Infundibular mucosa got gangrenous. Infundibular anterior wall looks a little bit pink color, but the mucosa is gangrenous. So it is like a frozen calyx. I'm not able to get the plane. So it is maybe cystic duct will be obliterated because of the distended infundibulum. Like, so I'm just seeing whether it's possible or not. It is entire gangrenous mucosa of the infundibulum. So all the infundibular mucosa is being removed, and then it is excised using the ultracision forceps. Check. You can see there is no green color covering of the infundibulum. So still some green color is there. Always we are trying for clipping of the cystic duct in all the cases. Very few cases, I can say in my practice it is around less than 1% of cases will go for the subtotal cholecystectomy, because nowadays our anatomical knowledge is good, and good imaging system, and preoperative imaging also we can see very CT or MRCP. So we will see the preoperative anatomy, and most of the cases we can able to go to the cystic duct and we can clip it. And this type of delayed presentation cases, entire thing is gangrenous, one thing. Second thing, some case short and wide cystic duct, it looks like an infundibulum, so we cannot go and clip it. So I can make a extra port, so that already extra port is there in the left lumbar. So I can make that make use of that port, so that I depress the duodenum down, and then I trying to dissect the so I'm giving was in all the places. So I'm giving was in the left subdiaphragmatic area, and so behind the spleen. So everything we can able to clean was and then suck. So we are very careful, should not injure the spleen. That area become frozen. That is a infundibular, cystic duct and CBD junction is frozen here. If I want to go for definitive clipping, then I may injure the CBD. So that is also not good. So just I'm just trying to separate. That is the CBD. You can able to see the well. That is the CBD. Mindsman touching suction nozzle is touching the CBD. So there is no place to apply clip here. Maybe if you use ICG in this case, it would have been helpful during the surgery time identification of the CBD. So this case is not done, but real ICG uses like this only. Whether I can go medial dissection for this now in this situation, or I can go for a subtotal. So the ICG will be guiding us in this kind of situation. So what I did, I excised all the excess infundibulum. It is only the small pouch of infundibulum is there, and the mucosectomy is also done. Anterwall even in the body of gallbladder and fundus of the gallbladder, again the mucosa got removed. So type 1 modification and type 2 modification is done already. So sometimes if you are forcefully doing it, no, it will come. If you remove the entire this thing, and you may go. Sometimes it will injure to the lateral wall of the uh, gallbladder. CBD will injure. So now I am removing the mucosa of the infundibulum. So this is considered very important in case of type 2 subtotal cholecystectomy. So that is the infundibulocystic junction, and here it looks like artery and wall together. Maybe I can trim this wall little bit. So this side it is very close to CBD. This is the edematous wall. That's why it looks big. So I'm taking a deep stitches. It include the posterior wall of gallbladder and the infundibulum both. I'm using a 20 Vicryl suture to close the infundibulum. See, you can see the bile is coming out. You can see the bile is coming out now. So that means there is no stone, all the debris material is released. And I am started suturing the post wall along with the infundibulum of the gallbladder. It looks like anterior side. Anterior side is look like thick. It is only the fat and the vessel. And if I try to remove this anterior wall, it may chance to injure the lateral wall of CBD is there. Some of the cases I could remove this with a cutting with the scissor, and then I could able to suture only the CBD instead of infundibulum. I suture the CBD. So now you can see it is cut throughing it. That's why if you leave a little bit thicker tissue, the cut through will not be there because it's a friable thing. So that's why that may be the reason I leave some of the part of the infundibulum. So this is the only little viable portion of the gallbladder because your entire gallbladder has become gangrenous. So we need some tissue to hold up when you are taking it suture. So I think it's better you leave some portion like this. Once you remove the mucosa, then it is need not to be worried about this collection, postoperative collection in this small pouch. Mucosa is the culprit. So if you remove the mucosa, then it will not enlarge postoperatively. And now you can see the very clear anatomy. CBD is very clearly seen, and this is the thickened portion of the anterior wall. It's look little big. Now you can see the bile is coming clearly. That is a bile. Next video I am going to put on ICG, use of ICG in gallbladder. Many people demonstrated straightforward cases, no simple lap chole cases. They use ICG and then they show the anatomy, but that is not a real use of ICG. ICG is a very difficult case. The ICG should use when a decision making is problem. At that time the ICG help should be there. Then that is the real use of ICG. I'm going to show next video. I'm going to put a next video like that, the real use of ICG, and so that will be helpful when you are going for a ICG in a lap coli. So I include the post wall of gallbladder along with this. So otherwise it is very much friable. Suture is when I tightening it is cut through the wall. So I am making very slow and gentle way of suturing it. So I put a Aberdeen's knot and then I tighten the knot because very less suture. So infundibulum suture has been done. So now remaining part of the gallbladder I am excising. It's already the anterior wall, post wall of gallbladder is left behind the liver. So it is a type 1 and type 2 combined. So it's a called type 3 modification. So all this gangrenous material mucosal of the gallbladder is removed. Some of the portion you can coagulate like this if it is a very densely adherent. The excised gangrenous gallbladder is being placed into the endo bag. So that is the excess mucosectomy, excess infundibulum got trimmed. So now it's placed into the bag and then I'm taking it out. So after thorough wash, drain is being placed. So it is a 24 size drain. So any leak in the infundibulum suturing, any bile leak is there, you have to keep this tube for 2 weeks, 10 days, 1 week to 10 days. Meanwhile, you can start ERCP, you can do ERCP and then you can remove this. So now I kept a subdiaphragmatic drain also in this case because there is a huge abscess was there. Thank you so much for watching.